On-the-scene coverage of ACC.14 is supported by Janssen Pharmaceuticals, Incorporated.
I'm Peter Block here at the ACC annual meeting in Washington, D.C. With me is Dr. David Holmes. David is from Mayo and needs no introduction. David, you've reported on the TVT Registry, the transcatheter valve registry, which is sort of real-life transcatheter valve outcomes. Tell me about the registry to start with, what it is,
Sure.
and then what this one-year report really tells us.
The registry was set up to capture the denominator of all patients in the United States undergoing TAVR. In the past, we've had subset of patients that we knew the numerator on, but not the denominator on. And we had the procedure being performed in very selected centers by selected physicians. As the technology rolled out, all of a sudden the number of patients and the number of physicians increased dramatically. And so this then registry was aimed at capturing that denominator. That was the first thing.
Okay, it's also linked to Medicare, isn't it?
The second thing was to say, what about linkage for 1 year data with CMS administrative claims data? And so this then is the first report of the TVT registry being linked at 1 year with CMS administrative claims data.
Okay, so having said all of that introduction, tell me what the one-year data are.
Sure. There were about 5,980 patients. That's sort of about. What we did was to look at then, number one, the baseline characteristics, and they were similar to other patient groups that have undergone TAVR. They were old, they had lots of comorbidities. STS score was 7 or a little bit more than that. We then looked at the in-hospital outcome, and that's not terribly new. The in-hospital outcome was good and was very similar to what other trials have been reporting. The most important thing we looked at was what the 1 year data looked like. At 1 year in this group of older patients with lots of comorbidities, the mortality was 26% about. The stroke rate was about 3%. When added together, it was about 28% of patients. A striking thing about it was that the majority of patients were alive and had not required repeat hospitalization during the first 6 months. So in terms of quality of life data, that's a big deal.
So the 5%, you didn't mention the 5% 30-day mortality, but that's what it was in this. That's actually pretty good, isn't it, considering? The 26% may be a little higher than you'd like. So tell me how you think you can interpret that. What does this mean? Give me the short version.
Sure. The short version is, number one, I think that these were somewhat lower risk patients early on. Number two, this was early technology. And so the number of events that could have related to that earlier technology might have impacted on 1 year mortality, such as the degree of paravalvular leak, which would have been higher with the early generation devices.
So essentially technology that we probably are going to see
Obsolete.
Disappear. Yeah, not quite obsolete yet, but probably going to disappear. And yet this gives us a pretty good indicator of where we stand in the United States.
The most important next part of this was to look at some characteristics associated with 1 year mortality and 1 year stroke.
Okay, so tell me what those ended up being.
So
Age?
what we found out was that age, age increases, as you could imagine, the patients have higher mortality. Number two, males had higher mortality. Number three, the rest of the sort of the usual culprits, chronic obstructive airways disease, abnormal renal function, STS, PROM, were all associated with increased mortality. The striking thing was that indeed there wasn't a relationship with anything else with increasing stroke except for female gender.
So the ladies have a little more higher chance of having a stroke. Thank you,
Less
David.
mortality, but higher stroke.
Thanks a lot.
Good.